For example, general. I think the first thing under general is weight change. Well, if they have a fever, but they have nothing else, say complains of fever, denies, weight change, fatigue, da, 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 okay? And then it has to, I don't need that to be drawn out. That can actually be kind of in a paragraph form, so to speak, but it does not have to be in complete sentences. When you think about a review of systems, and the minute you put the word denies, automatically assume that anyone who is reading that review of systems, with the exception of me, isn't going to read anything past the word denies, okay? Really, the only people who read review of systems long-term, and, hate to burst your bubble, are the coders for Medicare and Medicaid, okay? You're learning how to do a complete review of systems because you want to not go to jail. No.
So if we kind of use the final script as an outline, we should pretty much be covered.
You're going to be covered, and then some. Oh yeah. Perfect. But you got to make sure that your positives are going to be up front, and then your negatives are all second. Okay. And again, they should fit what diagnoses you gave them. They should fit kind of their HPI. They should fit their past medical, their past surgical history type of thing. Don't really tell me that somebody has absolutely no joint pain if you gave them a hip replacement and they're presenting with a fall and they hurt their hip again. Make sure in their musculoskeletal that they complain of joint pain, because that would everything should match. Yes?
When it comes to the day of the exam, we get our blank sheet of paper.
Yes.
I've had some people approach me and say, oh, I'm going to get my blank sheet of paper and I'm going to write out all my mnemonics and all that stuff. Is that what that is supposed to be? Because I don't want someone to get in trouble for writing all that stuff out.
You can write whatever you want on that paper.
Before we go in?
No. That paper comes in clean.
Okay.
Okay? But if you want to walk in and write down character, location, on situation, so that you remember, I've got to make sure I touch on all these things, the minute you walk in, that's fine. But you will basically get a piece of paper when you walk in. Yeah. Yes?
Are we reporting what we find back to anyone, or are we just asking all the questions?
You're just asking all the questions. In years past, they had people write that all up, but that's what I had to do basically an assignment for. So there's and essentially grades are due 3 days later or something, so. I want you to be able to ask all the questions. So I believe it's 50 points total, and you have to basically get 38 of the 50 to pass that section. Your quiz tomorrow, remember your quiz tomorrow starts at 9 a.m. It's 20 questions, 30 minutes to take it. I don't think I've allowed you to see your score, but I'll know the scores right away. And basically, if you studied my PowerPoints and you listened in class, you'll do fine. Behind you first.
So a couple of questions have also come up on that. Is it going to be more broader themes of the PowerPoints, or it's anything goes?
Anything goes.
Okay.
If I talked about it, it's fair game. Yes?
Are we lecture before or sleep?
You can sleep. Okay. And so tomorrow, I'll be here at about 8:30 tomorrow. I'm assuming Patch wants me in your afternoon lab. If she doesn't, and depending on if you're in Group A or Group B for the neuro exam, I'll be in my office if you guys want to show me your stuff before you would submit it on Thursday. But I'll certainly be here in the morning, after your quiz and all that kind of stuff. And just, yeah.
Tomorrow we can
Tomorrow afternoon, 1 to 5.
Yeah.
Welcome to Wednesday. Okay. Scrub day. All right, so let's get this finished up and get you out of here a little early. Although you guys probably have class 3 to 5, right? No. Oh, okay. Okay, I'm going. All right, so graphic right? So we're writing numbers in somebody's hand. We can do it on each other's neighbor. So you have that same paper clip and you bend it and you make 2 points out of it. And now we're going to talk about 2-point discrimination. So people, you guys should be able to poke each other on your arms and be able to delineate whether you're feeling 1 poke or 2. And it's not only important to be able to delineate 1 poke versus 2, but you should also be able to delineate how far apart you have to get before they can identify 2 separate stimuli. So they should be relatively close together, and you should be able to feel 2 separate points. Okay, we'll talk about the paperclip, 2 separate points on the paperclip. They shouldn't have to be a foot apart. for you to be able to delineate two different points. Okay, so again, normal clinical exam, if you're just maybe even a centimeter and a half apart, not that much, you should be able to delineate those two separate stimuli. So we talk about tactile point localization versus extinction. So again, you want somebody to close their eyes. You're going to touch two different parts of their body, touch their face, touch their arm. I almost always would touch the upper arm and touch essentially the upper part, like the quadriceps. And they should be able to tell you where you're touching. You're touching my right arm and my left leg, left arm, left leg, that type of thing. So they should be able to tell you where they're touching, and they should know that it's essentially a light touch versus a painful touch. You can kind of incorporate that into the examination as well. So they should be able to determine the two different parts on the body. Yes?
Can you do that unilateral, like you said?
You could, if you were worried about it being a unilateral issue, okay, so if you were worried only about, say, the right side of the brain, then you could touch two different parts on the left side of the body, because remember your motor cortex, HAL, so you could touch the arm and the leg and know, is your lesion more so in the lower aspect, in the leg? So essentially that would be the medial aspect of the motor cortex, or are we talking more of a lateral issue with the motor cortex, which would be the arm? Does that make sense? Okay, so yes, you can do it on the same side of the body. We talk about spinal reflexes. So biceps, triceps, brachioradialis for upper extremities. We talk about the abdominal, patellar, Achilles, plantar. We talk about biceps, pretty much you're almost always identifying C5. A little bit of C6 innervation. Again, remember your brachial plexus. Everybody kind of likes to hang out with everybody else, but almost always when people talk about biceps reflex, they're looking at C5. Brachioradialis looking more so at C6. Triceps looking more so at C7. Okay? Triceps are difficult to get on people. Always remembering that your elderly population will, in general, be hyporeflexic, and we'll talk about the grading of reflexes, but they're more difficult to assess a reflex on that patient simply because they've typically had more fine nerve damage over time. These are typically your patients who are diabetic, who've had chronic hypertension, who have chronic renal disease. So the innervation vascularly to their nerves has been poor. Okay, on somebody who has very bad proprioception and very bad vibration sense, you're probably not going to get the best Achilles reflex, just saying, on a diabetic patient. Okay, so don't go beating on them forever and hunting around for it, because it's probably not there. Okay, so you have to know when reflexes are abnormal and when it's just kind of a natural degeneration in your patient population. But again, typically your Achilles reflex almost always S1. Again, there is some crossing over there. Patellar, you're almost always looking at primarily just L4. There really isn't an L5 reflex to assess. So when we talk about deep tendon reflexes, basically +2 over is essentially normal. So that it's not really over anything, but a +2 reflex is considered a normal reflex. That's what we all should have in here. Somebody who is hyperreflexic, okay, a 3 or a 4, they're getting a little bit more jumpy. So then you're looking more typically at spinal cord issues. Why is the reflex pathway overstimulated? Okay, so think of it that way. Remember, when we talk about a reflex arc, we have to have intact input. We have to have a connection that's intact. We have to have an intact efferent limb, and we have to have an intact muscle for it to actually go into. So you have to have those 4 parts together to make your reflex arc actually intact. Okay, so that's why your elderly population, typically the reflexes are +1, and +1 for them is normal because they don't have that same afferent input, and they maybe don't have the same muscle bulk to go into in terms of actually obtaining a reflex. So one maneuver, you basically have them do a figure of 8 with their hands, and you have them pull apart. Okay, sometimes it's good to have them grunt a little bit, and basically it helps to distract the patient. This really only works for the patellar reflex. And the problem with that is you have a patient sitting there hanging with their leg off the side of the bed, and you're talking to them, and at this point you're like eye level with them. And so they're like, what are you doing? What are you doing with reflex hammer? What are you doing now? You're gonna hit me now? Okay, so they're not exactly in the most relaxed state for you to get an appropriate reflex. So if you have them pull their hands apart, they should put their hands in a figure of 8, pull it apart, it typically distracts them. So to the point where they can actually get an intact patellar reflex, if it's even there to begin with. So again, biceps reflex, primarily looking at C5, but it does cross a little bit C5 and C6. Almost always better if you kind of put your finger down and hit your finger, and that way you're not hitting them very hard. I know in these pictures that always showed a reflex hammer, one thing I always used as my reflex hammer was my stethoscope. The bell and the diaphragm of the stethoscope, because it was always around your neck. So I would always use that as my reflex hammer. It's like a twofer, okay? We talk about brachioradialis, so again, we're talking primarily C6. So if you have them semi-flex their arm and semi-pronated a little bit, you kind of relax that nerve a little bit more. Triceps, going to get some innervation of C6 and C8, but you're primarily looking at C7. So you're banging on the back of their arm. I was listening to a really cool ER boot camp seminar thing online, and one of the older doctors who's out of LA, he says, yeah, you just beat on everybody. You know, then those pediatric moms, then they think you really did something when you bring out the reflex hammer, you know. So you have to act like you know what you're doing. So we talk about umbilical reflexes. So basically you should just be able to brush on someone's abdomen. And if we have above the umbilicus, we're getting T8, T9, and T10. Remembering that the umbilicus is ballpark at about T10. So below that, we're getting T10, T11, T12. And you should see a fine contraction of the muscles. And again, you're just basically raking over someone's tissue, and you should get a little bit of contraction of that tissue. Very rare that you're going to be actually doing abdominal reflexes on someone. You're typically looking at that more so when we're talking like spinal cord injury, okay, in terms of assessing level of injury. Patellar reflex, so almost always this is looking at L4, a little bit of L2, a little bit of L3, but primarily L4. So you want to make sure that if you think they're going to be hyperreflexive, based on what their findings were on their sensory exam and their motor exam, I would suggest not to hit their knee and be standing right in front of them, because it will kick out and kick you if they're hyperreflexic at L, with a +4. They don't mean to, but just saying, happened to me before. So Achilles reflex, again, we're striking the back of the ankle, and basically the easiest way to do that, always you have to have an intact Achilles tendon. Okay, so for somebody who's had prior surgery there, you're probably going to have lost the reflex. But you can have them hang their feet over the back of the bed if you're having a really difficult time getting it while the patient is sitting. Okay, but typically you can assess it basically a little bit of flexion of the foot, and you can assess for an Achilles reflex, because you've kind of done the same thing as if you've taken the tension with their hands. By you pulling their foot up, you've kind of distracted them a little bit. Plantar reflex, again, so we're talking about Babinski sign. So a normal reflex would be for the toes to curl down. So you start from the lateral aspect of the foot, and you basically take the underside of your reflex hammer, or you take a pen and you draw it up the patient's foot. Their toes, everybody's toes should just curl, especially if you're really ticklish. If you have a positive Babinski sign, which is again a sign of an upper motor neuron issue, the toes will flare, and typically the great toe will flex up. Okay, so basically Babinski's is either present or negative. And again, typically you're not doing a patellar reflex on somebody unless you're really looking for some type of upper motor neuron issue. Cremasteric reflex, so cremasteric reflex only for you boys, okay? So basically if you stroke the inner side of the thigh, and it doesn't matter, you can either rub the thigh up or down, the cremasteric muscle should pull the ipsilateral testes up, okay? Biggest diagnosis that you'll actually have this finding is testicular torsion, which the dead giveaway for testicular torsion is it's like wicked painful, okay? But if you don't catch it, what's the biggest side effect or issue with testicular torsion? Necrosis and infertility, okay? So nobody wants to hear the necrosis word with the testicular word in the same sentence. Us girls, we feel the same way, okay? So, but testicular torsion, you're going to have an absent cremasteric reflex. For somebody who has a spinal cord injury, basically you're going to have an absent cremasteric reflex as well. So this is a little bit easier to see on your male patients than abdominal reflexes. Because, abdominal reflexes, we're hoping the person actually has abdominal muscles we can see. Somebody's 300 pounds, good luck trying to find an abdominal reflex, okay? But they will have a cremasteric reflex. Same thing to go for an anal reflexes. So this was always, my love when I worked neurotrauma, But truly, you cannot fake. You got somebody coming in and they're malingering and they say, malingering, faking it, and they're saying that they can't move something. Trust me, you cannot fake if you do not have rectal tone, okay? So that's a hard one, okay? So, but truly what they'll lose is they'll lose complete rectal tone. And so you'll go to do a rectal exam and there's no resistance there whatsoever and there's no sensation there whatsoever, okay? And honestly, if you've got that in somebody who has had a spinal cord injury, very poor prognostic indicator. The likelihood, no matter what you do, you can throw all the steroids at them in the world, of getting neurological function back is substantially lower, okay? So again, we're talking primarily S2, S3, and S4. Any patient who has cauda equina, okay, so if somebody who comes in, there's a diagnosis called saddle anesthesia. So basically, imagine how you would sit on a saddle on a horse. Anything that's the perineum, inner aspect of the thighs, a little bit of the tush area, and they can't feel anything. And typically, it happens secondary to a very large disc herniation. It does not necessarily have to be with a huge amount of trauma. And they have cauda equina, and they basically will stroke out their nerve roots distal to the herniation if they don't emergently go to the operating room. Okay, so easiest thing to do, their cremasteric reflex would be gone, anal reflex would be gone. So on clinical exam right away, that with saddle anesthesia, because they might still have some motor function in the legs. You know that you're getting them an MRI and you're calling the neurosurgeons. They're going to the OR. Clonus, so clonus is essentially a abnormal finding. You should be able to gently pull someone's foot up, and it should not beat against your hand. Okay, so all right, come here, John. All right, so sit right here. So we talk about clonus. Oh, okay. This cracks my knees. All right, so when you talk about clonus, you're going to pull someone's foot up, and you kind of relax your foot. Be relaxed. Okay. So John, he's relaxed now. So you relax your foot and you pull the foot up, and you should not feel beat down against your hand. If you feel him beating against your hand once you've forcibly flexed his foot, that is considered clonus. And then you note whether it's 2-beat clonus, 3-beat clonus, 4-beat clonus. Okay. Clonus directly goes with patients who are hyperreflexic. Okay. So if you hit their patellar reflex and their foot kicks out, it should not kick out and kick you. Essentially, it's a 4+ patellar reflex. The next thing you should be going for is looking at clonus, okay? Because then you're gonna basically relax their foot, and that's all you do. Relax your foot, kind of wiggle it around so that they're distracted. You force it flexed, and it should not beat against your hand, okay? Thank you. How's participation today? Okay. So it's that rhythmic auscultation. It's just boom, 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 boom. And then it settles down. But you want to count how many times. Is it 2? Is it 3? Is it 4? Okay, because that's what your neurologist is going to want to know. Again, normally this should be absent. Okay, this should not even, a lot of times you don't even get to this part of the assessment because everything else in the neuro exam has been stone cold normal. So we talk about cerebellar function. Again, we're looking at motor, cerebellum, vestibular sensory system. Everything has to integrate for that most posterior aspect of our brain to be functioning properly. And we're going to do rapid alternating movements. We're going to go heel to toe. Again, here we're assessing a little bit more of our gait because we're looking at balance and coordination. We've already assessed proprioception within our joints, so we know whether we plus or minus might have a little bit of problem there. Floyd, I see you doing a little clonus with your finger right there. I gotcha. There you go. So finger to nose, okay, so this is basically your drunk driving test, okay? But you basically say, take your finger and touch your nose, now touch my finger, now touch your nose, now touch my finger, touch your nose, now touch my finger. And they can look at your finger as you're moving your finger. And they should be able to do it back and forth. You'll have some people, they come back to their nose and they're over here. That's a problem, okay? Unless they are drunk, but I mean, they really, 10 o'clock in the morning, you never know. But they should be able to come right back to their nose. You have other people that go to hit your finger and they're doing this. Okay, because their cerebellar function's off. They can't get from here to here in a straight line, okay? I did have one patient one time, he tried to use his nose to touch my nose. I'm like, whoa. Hold on there, Turbo. Okay. So typically, if they can do it straight up and back, then you have them close their eyes and they should be able to go straight up and back. But almost always you start with eyes open, and that's when you can move your finger around. Don't expect them to close their eyes and magically know where your finger moves to, okay? So heel to shin. So basically it's a similar thing that you're doing with finger to nose, but you have them put their heel on top of their shin. They should be able to run it all the way down to essentially their ankle and all the way back up. And then you have them do it the other. And you would be amazed, especially with stroke patients, their foot will fall off the side of their leg because they can't keep it straight on the top of their shin, okay? Rapid alternating movement. So, and everybody has hand dominance with this one as well. Basically, you tell them, take your palm, take your hand, and wrap it back and forth, okay? And then here, wrap it forward. So basically, everybody can tell that I'm left-handed, right? So my hand, your rapid functions are going to be a little bit stronger, a little bit more fluid on your dominant side, okay? So you can do that. The other thing you can do is have them touch their thumb to their fingers. 1, 2, 3, 4, 4, 3, 2, 1. It should be able to do back and forth, okay? For rapid alternating movements. For station and stance, you want to watch them walk, okay? For Romberg sign, basically you're going to have them close their eyes. Sometimes you can have them put their palms out, but in theory they should just be able to stand there. Feet shouldn't be straight together. Knees should not be locked. But you have them stand there and just relax. They should close their eyes, and they should not fall, okay? So always what you do, let's see. Oh, I'll use you now. Come here, stand up for me. Yeah. Class participation. So what you do with Romberg is you want to make sure that you stand on the side of them, because if they're going to fall, most people fall backwards, okay? But you want to make sure if they're going to fall forward that you're protecting them in both areas. So you're going to stand there, you're going to close your eyes, and you're just guarding them, okay? So if she was to list backwards or forwards, you could be able to catch her and guard her either back or forward, okay? You don't want to stand right in front of them, because if they go backwards, good luck. That's a head injury waiting to happen, okay? And conversely, you don't want to stand behind them and have them fall forward. So again, you're looking for evaluating that cerebellar function and making sure their cerebellum is intact. We talk about pronator drift, so we see this a lot with our stroke patients as well, but any type of upper motor neuron issue will could potentially give you a positive pronator drift. So arms are going to be straight out in front of you, and basically you close your eyes, and you should not see. What will happen initially is an inversion of the arm, okay, before it drifts down. So again, it's another way to assess for strength, but basically both arms out, and they should be able to both stay out. One should not start to drift and turn medially and then drop down. So you'll see that with stroke patients. You'll see that with upper motor neuron issues. Again, their gait, so tandem walking, they should be able to do the drunk driver test, right? They should be able to go heel toe right in front of each other, okay? They should be able to walk up on their tiptoes and back on their heels, and be able to keep balance. So again, you're assessing muscle bulk and tone at that point as well with that exam, bless you, but you're also assessing for cerebellar function. You can make them stand up. They should be able to rise from a seated position as long as they don't have an insane amount of orthopedic issues or, like osteoporosis, but like osteoarthritis. You are going to have some patients that have a difficult time arising, but they should be able to do it, and it shouldn't be a sudden change. This is the same person that when you walked into the room, they had a hard time sitting down. So if they have a hard time sitting down, they're going to have a hard time standing up, okay? But again, everything should kind of fit together. The puzzle should start to make sense. Hop in one place. I have had patients do that, so you hop on one leg, like a flamingo. And that will let you know also, again, assessment in terms of quadriceps and just balance, but also muscle tone and bulk of the lower extremities. And so again, very quick review. So we do our mental status exam, which pretty much we're going to glean in that history that we're taking for the patient, because we're making sure that they don't walk in disheveled, that they look like they showered today, and that they washed their hair this week, okay? That their teeth are brushed, like all that kind of stuff. Patient walks in, just think of my Uncle Johnny. Patient walks in not wearing shoes, we got a problem, okay? God rest his soul. Cranial nerves. So we're assessing all of our cranial nerves, okay, looking at our cortical bulbar tracts, making sure we have appropriate input and output. We're looking at motor function, looking at our sensory function, reflexes, and cerebellar function. And again, everything should start to fit. The only times where if we have stuff that everything is kind of like all over the place, you got to start thinking about multiple lesions in the brain. So multiple lesions in the brain, thinking MS, thinking metastatic cancer. There's not a whole lot of stuff that's going to hit multiple areas, unless someone's had a history of steady deterioration with repeated strokes. Okay, so again, it should be kind of focused to one section of the brain, unless you're talking about more disseminated neuropathology. All right, any questions? Everybody ready for the quiz tomorrow? Okay. All right, guys, have a good afternoon.